So actually, in the morning, I was thinking about this thing that many people come to us with this complaint that I feel I am unsteady, I am shaking, I feel as if things are moving, shaking, different things. And then their concern is whether they have vertigo, right? So I was asking you, and you were saying all dizziness is not vertigo. So you want to tell me something about those things? What to, how to, know whether it is vertigo or something else?
Dizziness or giddiness is a very general term or a vague term that could mean anything. It could mean the patient has lightheadedness, or it could mean blackening of vision, it could mean imbalance, it could mean maybe true vertigo. So, vertigo is a specific type of dizziness where the patient has self rotatory feeling or feeling that the surrounding or the environment is rotating around them. So, any other thing, anything other than this is not vertigo.
Right. So what are some of those conditions where people can say dizziness, but it's not actually vertigo? Some of those conditions, can you talk about them?
Dizziness is a vague term. It can be because of various causes such as anemia, low hemoglobin, dehydration, electrolyte imbalance. That is, when somebody has had a acute gastroenteritis, loose motion or vomiting, and they have some electrolyte imbalance, and they can have giddiness or lightheadedness for a few days after that. Low BP, low sugar, all these can, anxiety also can cause giddiness. So when somebody comes with dizziness or giddiness, then it is very important to take a detailed history and examination to find out what kind of dizziness it is. And it's important to ask about history of anti-BP medications, especially if they have taken it very recently. So many anti-BP medications, they have the tendency to drop the blood pressure. So especially when you're sitting and suddenly getting up from the sitting position, or you're lying down and suddenly when you get up, then your BP can go down, and then you can have giddiness. And also it's important to ask about history of prostate medications. Prostate medication can also, it is very notorious to cause low BP, especially when you're getting up from your sitting position or lying down position, and can cause giddiness or lightheadedness. So these are the causes of dizziness or giddiness in general.
So how would you know the difference, and how do you manage a situation where somebody has intermittent, episodes of dizziness?
So when patient comes with history of vertigo, again it's important to take a detailed history as to what kind of vertigo it is. So the most common causes of vertigo include something called a BPPV, that is benign paroxysmal positional vertigo, vestibular neuronitis, labyrinthitis, Meniere's disease, migraine. These are the common causes of vestibular migraine. These are the common causes of vertigo. So there's an entity called BPPV, that is benign paroxysmal positional vertigo, which is more commonly seen in an elderly population, or past middle age. So they typically give history of vertigo when there is a positional change, or when there is a head position change, they have vertigo. So this history is very important, positional vertigo. So and it's always recurrent or paroxysmal. It is intermittent, and in between the episodes, the patients are absolutely normal. And during the episodes, they can have intense vertigo, nausea, vomiting, or feeling of imbalance and difficulty to walk. But once that episode is over, they're completely all right. So when somebody comes with this BPPV episode, then it's very important to give them, not just the medication, other rehabilitative measures also. So when somebody
Mm.
comes with a BPPV episode, we give a short course of medicines such as labyrinthine suppressants, that is our beta histine, cinnarizine. But it's very important to give it only for a short period, and after that they have to resort to other rehabilitative measures, exercises, vestibular rehabilitative exercises, lifestyle modifications, etc. The reason why I said this is, if you give these medicines for prolonged periods, there's an entity called maladaptation or non compensation, whereby the brain doesn't compensate if you keep giving the medicines. And they will always have that apprehension of fear that they'll get the vertigo anytime. So there's a persistent vertigo which happens in maladaptation or non compensation. So we give a short course of medicines, and then they have to go for the exercises or repositional maneuvers. The ear apparatus can be divided into three parts. One is the external ear, then the middle ear, the internal ear. So in the internal ear lies something called a labyrinth, then our ear nerve or the eighth nerve. These are all inside the inner ear. So any inflammation of these parts also can result in vertigo. There's something called vestibular neuronitis, that is the inflammation of the eighth nerve or the balance nerve, the nerve that controls the balance. So any inflammation can also produce similar symptoms such as vertigo, nausea, vomiting, and it usually resolves by itself within a span of 2 weeks. Short course of steroids may have to be given. And the point to be noted here is vestibular neuritis is usually a one-time event. It never recurs. Then labyrinthitis also can, that is inflammation of the labyrinth, that is the inner ear, also can produce vertigo, nausea, vomiting. Then there's an entity called Meniere's disease. Meniere's disease, it's a chronic progressive condition. So the patient will come with history of on and off vertigo since many months, which is progressive. Then progressive hearing loss, then ear fullness, then tinnitus, that is an abnormal sensation coming from inside the ear. So these are the symptoms of Meniere's disease. So again, from the history and examination, we'll be able to find out that this is Meniere's disease. Then there's something called vestibular migraine. Again, vestibular migraine and BPPV, the symptoms could be very similar because vestibular migraine is also a very recurrent condition or paroxysmal condition, which can come on and off. It can come with headache or sometimes even without headache. Vestibular migraine episodes can occur. So these are the conditions of pure vertigo. So by clinical examination history, we'll be able to find out what the exact cause of vertigo is, and we can treat accordingly. And like I said, in the episodes of in between the episodes of BPP or vestibular migraine, the patient is completely all right. They don't have imbalance. If somebody has vertigo, nausea, vomiting, and imbalance is persisting, definitely we should reconsider our diagnosis and immediately subject the patient for an MRI of the brain, because stroke at the back of the brain, something called a cerebellar stroke or a posterior circulation back of the brain, stroke can present with vertigo, nausea, vomiting, and imbalance. And there the point is imbalance is persistent.
And there is one question that I can see. It has been repeated a few times, so we'll maybe just address it. Uh, when Sushma Gupta, आपने पूछा है कि मेरे पीछे वाले सुराग में बड़ी खुजली हो रही है। पॉइंट इज़ आज हम वर्टिगो और डिज़ीनेस के बारे में बात कर रहे हैं, तो ये थोड़ा ऑफ टॉपिक हो जाता है। और दूसरी बात है कि ये खुजली अगर हो रही है, तो खुजली तो प्रोबेबली इट इज़ रिलेटेड टू स्कैल्प, यानी हेयर में या स्कैल्प में कुछ हो रहा होगा। तो उसके लिए ना डर्मेटोलॉजिस्ट को दिखाना बेहतर होगा मेरे ख्याल से। तो लेट्स गेट बैक टू आवर टॉपिक। वी वर टॉकिंग अबाउट डिजीनेस। क्या होता है ना कि मेनी पीपल यू नो दे हैव हैड एपिसोड्स ऑफ डिजीनेस or vertigo, actual vertigo, and they have recovered. And then they keep getting episodes of intermittent, uh, like feeling a perception of dizziness in certain positions. When I turn, suddenly I feel shaky. So, what is that called, and why does it happen, and how do you handle these things?
From a previous episode, they would have taken medicines for a long time, and then the dizziness is persisting because of maladaptation. Or there's something called a persistent perceptual postural dizziness. This is very common in young individuals, and it's very strongly linked to anxiety, stress, etc. So here the patient will feel that they have a persistent vertigo, especially when they see when they are in crowded places or like a mall. They feel that they'll fall, or they have a vertiginous feeling. So it is again treated with short course of SSRI, a class of medicine called SSRI, lifestyle modification, exercises, etc. So there's another thing that I wanted to say. So dizziness also could, many patients when they say dizziness, it could also mean imbalance while walking. So again, imbalance, the causes of imbalance is a different set of causes. So neuropathy, that is especially in diabetic individuals, if they have significant neuropathy, the nerves, they won't be able to feel the sensation of the floor. They can have imbalance. So it's called pseudo vertigo in neuropathy. So again, when somebody says they have imbalance, we should work up for neuropathy. Or cerebellar disorders. There's a structure at the back of the brain called the cerebellum, which controls the or maintains the balance. So any problem with the cerebellum also can produce imbalance, like a tumor or a stroke or any lesion in the cerebellum can produce imbalance. Then there is a chronic progressive disease called Parkinson's disease. It can also present with imbalance and recurrent falls. So it's again important to find out by a detailed history and examination what exactly is the cause of the imbalance. Also, it's very important to subject a patient to cardiac evaluation if they say they have pre-syncopal attacks or fainting episodes associated with palpitation. So we all know that our heart beats very regularly. So any change in the regularity of the heartbeat also can produce imbalance or faintness near syncope episodes. Yes. Sir, I think I have to go now. Okay. Okay.
Dizziness and other neurological conditions. Very nice talking to you, Dr. Ponnu, and I'll see you again another time.